Halo, on call story. Post call 2 hari. Lepas tu on call hari tu ada newborn polycythemia. So neonatal polycythemia. Lama dah tak dapat. Okay, so I think term baby 3 kilos, 38 weeker, mother antenatal, GDM. I can't remember diet control ke insulin. Uh, but the admission is because of cover for sepsis, because mother got some pus along the vaginal tract, so we admitted the baby for presumed sepsis, started on antibiotic lah. However, the FBC hematocrit show reveal 70%, so is way above the cut-off point of polycythemia. Polycythemia is 65 and above lah, and this baby is definitely polycythemic. Okay, so and then clinically also he is polycythemic, very plethoric looking, very red. Okay, however, other than just being very red, baby was asymptomatic. Okay, so asymptomatic means there were no features suggestive of polycythemia lah. So if we talk about polycythemia, so why this baby at the risk factors is because mother GDM. Okay, so anything that can cause problem with the blood flow, placenta blood flow, meaning the perfusion to the babies is affected. So that one will trigger the compensation mechanism where baby need to produce more red blood cells to basically compensate to deliver more oxygen to the organs. Okay, so anything that disrupt the placenta, causing placenta insufficiency, for example your preeclampsia, GDM. Okay, those two are basically the most common example that can cause placenta blood flow problem or placenta insufficiency. Okay, so this placenta insufficiency will cause will be the risk factor for polycythemia in babies. Okay, so GDM babies most of the time. Alright, other causes like delayed cord clamping. The normal delayed cord clamping that practiced by the ONG usually about 10 seconds. That one won't cause polycythemia per se, but because that one will help in terms of prevention of anemia, because it allows some bloods to basically flow back to the babies post delivery. However, if the cord clamping is too long, like one day the one like happen in home birth, usually when the cut wasn't clamped properly, wasn't clamped on time, or just being left until the nurses come, that one is the true delayed cord clamping lah. So that one will definitely cause polycythemia. So what are the symptoms? What are basically the symptoms for neonatal polycythemia? If baby is symptomatic, meaning baby has the symptoms of polycythemia, we can basically go through by the system. The brain also can be affected, because as you know, when there is polycythemia, your blood is quite viscous, quite thick. Imagine your highway congested with cars, too many cars, so there will be traffic jam, the cars moving slowly. So same as your blood flow, when you have too many red blood cells, it become very viscous, and the blood flow to the vital organs are affected. So if the blood flow to the brain affected, your baby can look lethargic. Okay, so not feeding well. So those are basically the symptoms for the brain related. Then your blood flow to the lung not good, meaning the blood's not receiving enough oxygen, not delivering oxygen to the organs. So yeah, the recipe wise, the baby will be tachypnic and having respiratory distress. Okay, and then your saturation also not good because of delivering of oxygen to the organs also not good. So saturation can be low. Alright, and then what about the gut? And then because of the perfusion to the gut's not good, meaning hypoxia to the gut. Your gut basically not able to function normally, so there will be feeding intolerance, the vomiting. The worst case scenario, because of hypoxia, until can cause tissue problem, tissue necrosis and all that gut. So later on can develop necrotizing enterocolitis. Okay, so what about metabolic symptoms? Usually because of increased number of red blood cell, there will be increased glucose consumption by the hemoglobin itself, by the red blood cells. So there will be symptom of hypoglycemia. So those are basically at least the 4 or 5 common symptoms that are related to to the polycythemia. In the baby that we saw during on call, the baby basically asymptomatic. They don't have don't have much symptom except looking plethoric. Okay, so based on the symptoms, the monitoring is very important to basically specify the specific things you want to look for during monitoring. So we must monitor the blood glucose regularly, maybe 3 hourly, 4 hourly, 6 hourly. It depends. You don't have to be very anal about it. It can be 3 hourly, it can be 4 hourly, 6 hourly, depend on your centers. If you don't want to poke baby so much, maybe you can do 4 times a day, maybe you can do 3 times a day, maybe you can do when baby is symptomatic. Alright, other than that, you basically during your round must observe for respiratory distress, and then must observe for baby activity level, whether active on handling or not, or looking lethargic, and then of course you monitor the feeding, whether baby feeding well or not. Okay, one more symptom that I forgot to talk about is basically jaundice. So polycythemic baby, they will be easily jaundice because your red blood cell is a lot. So in neonatal RBC, usually they can lyse faster compared to normal adult hemoglobin. So when your red blood cell hemolyze, it will release jaundice. So this baby will be jaundice very fast. Can be jaundice like pathological jaundice within 24 hours, and also can be jaundice later on at day 2, day 3 of life. So jaundice is also one of the symptom of polycythemia. Alright, so how do we treat polycythemia? The management of polycythemia, it really depends on the babies, and then it depends on the hematocrit level. Okay, if the hematocrit is more than 65 to 70, that baby are asymptomatic, and then usually we just monitor, observe, do the blood glucose from time to time to watch out for hypoglycemia, and then monitor for the other symptoms such as your respiratory distress. Okay, in terms of fluids, we want to dilute the blood, so we want to give more blood first. Either if baby asymptomatic can feeding well, you can give feeding, but 1 day ahead. Usually what we talk about 1 day ahead is total fluid during day 1 of life. During first 24 hours of life are 60 ml per kilo per day, but you can give more, 90 ml per kilo per day. Okay, if you want to be more aggressive, you can start the drip 1 day ahead as well. So when you start the drip, you can monitor your bloods after 6 to 8 hours after you start your IV drip or feeding, to see whether the hematocrit level reduce or not after you start the drip or you give more fluids to the baby. Okay, that's basically the first treatment. Alright, next, what if the baby is 65 to 70% level of hematocrit? What do we do if baby is symptomatic? Then you can go for a partial exchange transfusion. Okay, if baby also have no symptoms but the hematocrit level more than 70, you can also go for partial exchange transfusion. Okay, what is partial exchange transfusion? Basically, in a normal exchange transfusion, we like for ET level neonatal jaundice, we transfuse fresh whole blood, and then we remove baby's blood that have a lot of bilirubin, and then we replace 1 to 1. Okay, so that will bring down the bilirubin level, but it won't bring down the hematocrit level. So for it to bring down the hematocrit level, so instead of transfusing blood, we replace that fresh whole blood with normal saline. Okay, so we only take out the bloods, but we replace, instead with the blood 1-to-1, we replace it with normal saline. Okay, so this will reduce the hematocrit level within 2-3 hours after you finish your exchange transfusion. Okay, there are formulas when you want to do partial exchange transfusion. In the normal exchange transfusion, like for exchange transfusion because of the very very high neonatal jaundice, we usually go with the formula double volume exchange transfusion, which is 2 times body weight times 80 ml per kilo. Okay, so that one is double exchange transfusion volume for the high bilirubin. For partial ET, usually is a single volume, meaning you just body weight times 80 ml per kilo. Okay, but we can also calculate based on the desired hematocrit. Usually the desired hematocrit level is 55. Okay, so the formula is basically the hematocrit level, for example 70s, then you minus 55, and then you divide by the 70s, and then you times that with the body weight times 80 ml per kilo. So that will give you the volume that you that were needed to basically to do single volume exchange transfusion for polycythemia. Okay, so that's basically just some basic guidance on how do we deal with polycythemia, neonatal polycythemia. Okay.